It's about congenital uterine abnormalities. I would request Arun to start the prayer. Arun, please.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Arun. Dr. Vidya. Dr. Vidya, are you around?
We will wait for Durgadas sir and what?
Dr. Durgadas is busy. He conveyed his wishes to us.
Yeah. Okay. Arun, will you display Shilpa Madam CV? Dr. Shilpa Haresh. She is from Bangalore, senior consultant and gynecologist and IVF consultant from Bangalore, Satvam Fertility Center, Rajeshwari Grantham Foundation Hospitals, Rainbow Children Hospitals, and she is the ART and Infertility Reproductive Medicine Chairperson, Kasova for 25-22 to 27. She has 21 years of experience in the field of infertility, presented in various conferences, and her areas of interest are PCOS and poor ovarian reserve, presented papers on non-obstructive.
You can make it short, Dr. Vidya.
Yeah. And she got Rising Star Award in KISA 2026. Let's start.
Can we have a few words from Dr. Shobha? Madam, are you around? Shobha Gudi, Madam. Dr. Rajeshri Palladi, our upcoming Kasoga president. Madam, have you logged in? Okay. So, Dr. Vidya.
Yeah.
Okay. Arun, please share Dr. Vidya's CV. Dr. Vidya is MBBS DGU DNB. She's fellow in reproductive endocrinology. She's MSc in sexual counseling, infertility consultant, Spandan Hospital and Janani Fertility Center, Hubli, member of Art Kasoga Committee. Welcome, Dr. Vidya. Now, please carry on with today's webinar.
Yeah.
Thank you.
Good evening, all the KISAR and Foxy office bearers, and good evening, my speaker, Dr. Bharti Madam, and all the panelists and experts present today, and all the participants of the webinar. It's my pleasure to be the part of this discussion on congenital anomalies in infertile patients, which is deeply relevant to reproductive medicine. And without wasting my time and your time, I want to introduce Dr. Anuradha, chairperson for the topic talk today. Dr. Anuradha Kher, as you all know, she is well-known personality all over infertility groups. She is now secretary of KISAR chapter of ISAR, and she is practicing in Bangalore, and she has 20 years of experience in infertility, various articles and authored many textbooks. Director of Nurture Fertility Bangalore. Madam, welcome. Please introduce the speaker.
Yeah, thank you so much, ART Committee Kasoga, Dr. Shilpa and Dr. Vidya for giving this opportunity. It's an honor and privilege to introduce our key speaker, Dr. Jaya Bharti V. She is President Bhadradri OBG Society, Kottagadam. I'm sorry if I am not pronouncing it well. Telangana State. She has done her graduation and post graduation in OBG from Kurnool Medical College, Andhra Pradesh. She has received a lot of gold medals in various subjects and is a very good has been a very good student. Diploma in ultrasound from Iron University, medical school ultrasound. It is a certified NT scan from FMF UK, Advanced University Certificate in Fetal Medicine, Barcelona. She is a member of the prestigious International Ovarian Tumor Analysis Group in ultrasound. Foxy HPV Champion Award she's got, and presently executive member Society of Fetal Medicine Telangana chapter, joint secretary of TCOG, and she's presently doing her private practice in Jayabharti Multi Specialty Hospital, Bhadrachalam, Telangana. A warm welcome to you, madam, and it's a privilege to listen to you. Please start your session.
Thank you, madam. Can I share my screen?
Yes, ma'am.
Is my screen visible?
Yes, ma'am.
How can I get the pointer?
Will you help her, Arun?
Arun,
Yes, ma'am. Yes, ma'am.
pointer.
Yes, ma'am. Start sharing, ma'am.
Yeah, I've already shared.
No. It has been closed again.
Now,
No, ma'am.
should I do it now?
No, it's not
No.
seen.
It was visible earlier, ma'am, but it has
No,
gone now.
it's been closed. Once again, you start sharing, ma'am. Yeah.
And start.
Yes.
Yes.
Yeah,
Yeah.
now it is
Yeah, ma'am.
seen.
Make it
Full screen.
slideshow,
Is
ma'am.
it full screen now?
Yes.
Yes.
Are you still there?
You can go to the next one, ma'am.
Yeah. Is my pointer visible? My pointer visible?
Yes,
Yes,
ma'am.
ma'am.
Okay.
It is
Thank you.
Ma'am,
a
Thank
red
you.
dot. Yes.
Yeah.
Red dot.
Yes. Okay. Thank you, Madam Chairperson, for the introduction. I would like to express my gratitude towards KISAR for choosing me. Respected Chair, senior dignitaries, the office bearers, eminent faculty, and dear delegates. Here I go. Smart diagnosis of Konuta. Konuta is a mnemonic for congenital uterine anomalies. So my place, Bhadrachalam, is very famous for Lord Rama. So I bring with me the blessings of Lord Rama for all of you from Bhadrachalam. The prologue. A 16-year-old girl presents with primary amenorrhea. Her scan report shows absent uterus, and you can see the right ovary. So this is a case of Mayer-Rokitansky-Kuster-Husser syndrome. A 24-year-old history of 2 mid-trimester abortions comes for workup. Her ultrasound shows subseptate uterus, and she needs surgical correction in view of bad obstetric history. A 24-year-old Hello.
Yes, madam.
Something is masking my screen in the upper part. How do I close this one? The upper one, audio, video, that bar is masking my screen.
There is okay.
Alt, press Alt, ma'am. Press Alt. In your keyboard, press Alt.
Yeah, but it's not disappearing.
Now, slowly it will be moving towards up, ma'am. Just press and leave it.
Okay. A 24-year-old with history of preterm labor comes with 2 months amenorrhea. Here the scan image, it's a complete septum gestation sac in the left hand. So she requires cerclage. A 35-year-old with 2 full-term normal vaginal deliveries now presents with dysmenorrhea. So it's a case of unicornuate uterus. A 40-year-old with 3 living children now presents with heavy menstrual bleeding, and this is a complete uterus. A 14-year-old with severe pain abdomen with syncopal attacks. And this image shows a big vagina with collection, and there is collection in the uterus. You can see the catheter in the urinary bladder. So this is a case of hematocolpus and hematometra. It's a case of imperforate hymen which requires immediate surgery. A second gravida, G2P1L1 16 weeks, comes to me with a report done outside showing a solid ovarian tumor. When I did my scan, there was a solid right ovarian cyst, but it was showing plenty of vascularity. A tentative diagnosis made, a decidualized endometrioma, and she was followed up. At 34 weeks, she presents with footling and PROM, and an emergency LSCS was done. To our surprise, it was a uterus diadelphus. So then I went back to my archive. Again, we evaluated the images. This was the solid ovarian cyst, what was shown earlier. And now, when I carefully followed this up, it is the decidualized endometrium of the other heart. So images may not speak truth always. Conduita, how do they present to the clinician? What is the role of a sonologist? So coming to the dialogue proper. Conduita may present as subfertility, recurrent pregnancy loss, pregnancy complications, pelvic symptoms, or it can be completely asymptomatic also. The incidence is 4 to 7% in general population and 6 to 7% in infertility clinics. So my talk will be under these headings: embryology, diagnosis, measurements, types of anomalies, description of anomalies, and finally, the reporting. Well, you all know the embryology. Uterus develops from Mullerian or paramesonephric ducts and sinovaginal bulbs. Development starts by 6 weeks and is completed by 20 weeks. So in male, where there is Y chromosome, the SRY gene is present, so it secretes testosterone. So there is persistence and differentiation of mesonephric ducts and regression of paramesonephric ducts. Whereas in female, there is no SRY gene, so there is no testosterone, which leads to regression of mesonephric ducts and persistence of paramesonephric ducts. So we have two Mullerian ducts. They grow caudally, bilaterally. When they come in close contact with the sinovaginal bulbs, they stop growing. This is formation. So slowly they start fusing together. This is second step. And the third step is resorption of the intervening septum. So the Mullerian ducts stop growing until they touch the urogenital sinus. Here the sinovaginal bulbs are formed, a vaginal plate is formed, so that is causing development of lower 1/3 of vagina by the sinovaginal bulbs. So please remember that resorption is always from caudal to cranial. From caudal to cranial, the resorption occurs, which is the crucial for our developmental defects. So the embryological aberrations are of three types: developmental defects, fusion defects, and resorption defects. Coming to the developmental defects, we have uterine aplasia. Already I have shown you the image. There is complete absence of the uterus, but rudimentary horn or horns may be present. We have to look for that. So uterine hypoplasia is nothing but a small uterus and unicornuate uterus. So this is absence of uterus, even the cervix, sometimes the vagina also. But ovaries are always present and the fallopian tubes are also present. This is the same image. So uterine hypoplasia is nothing but a normal small uterus. So this is a small uterus. The measurements are 3 into 2 into 1.5. Normally, the uterus and corpus ratio, corpus to cervical ratio is 2:1, whereas in hypoplasia it is 1:1 or sometimes 1:2 also. So coming to the important one, the unicornuate. Here we are more worried about the rudimentary horn. You observe these 4 images. Here there is no horn. Here we see the horn, but there is no cavity in the horn. The cavity is seen here and it is non-communicating. And the last image is cavity is seen and this cavity is communicating with the main uterine cavity. So by far all the things, the cavity with non-communicating horn is the most troublesome one and also most difficult to diagnose because we have so many DD in this category. Coming to the fusion defects, we have uterus diadelphus, bicornuate uterus, and atypical fusion defect is Overa syndrome. Uterus diadelphus is complete non-fusion. We have 2 uteri and 2 cervices. This can be symmetrical or asymmetrical. And the second category is bicornuate uterus. Here it is incomplete fusion. We have 2 uteri plus single or double cervix. Can be symmetrical. If the woman is parous, it is asymmetrical. The resorption defects. We have finished the developmental defects. Now the resorption defects are most common ones. We have complete septum, incomplete septum, arcuate uterus, and atypical septum is Robert's uterus. So how do you diagnose Onuta? So the suspicion is always there on the 2D image, whether it is transabdominal or transvaginal. So timing of the ultrasound is more important. So for Conuta, we do the scan usually in secretory phase, but for the intracavitary lesion, we do our scan in proliferative phase. So when you have a suspicion on 2D, then you confirm with your 3D. But you have to keep in mind the limitations of transvaginal sonography, and we will also see what is the role of MRI. So how do you have a suspicion in 2D? So whenever you introduce a transvaginal probe, you immediately find out that the uterus is not in midline. There is unusually broad fundus. On axial image, you see endometrial refringence as 2. The endometrium is showing 2 echoes. Sometimes you see 2 separate uteri. There is varying length of endometrium on sagittal sweep. This is more important for septum. So the timing of USG, we usually do it pre-ovulatory or secretory phase. Why? Because the hyperechoic endometrium gives a good contrast against the hypoechoic myometrium. So that is the ideal contrast. So how do you confirm? So it is by TVS 3D. So 3D is 98.38% sensitive and 100% sensitive, specific. 100% specificity. If you don't find any anomaly on your 3D, it can be 100% sure that there is no anomaly. So you can combine your 3D with color Doppler. Some sonologists use saline infusion sonography, but personally, I don't recommend for diagnosis of Conuta. For complex or cervical or vaginal anomalies, you may use gel sono vaginocervicography. For young girls, unmarried girls, you may have to use transrectal ultrasound. So finally, the diagnosis by 3D coronal image. So the billion-dollar question is how to acquire a good volume. So acquisition of good volume. Now I tell you the tips and tricks of acquisition of good volume. So first step is optimization of 2D image. To have a good volume, it is always a good 2D image that is required. So usually for all gynec scans, we use a low gain. But for 3D, you have to increase your 2D gain. You select your 3D button, you select render or multiplanar button, adjust ROI, include only the area of desired anatomy. So this is how you adjust your gain. For 2D, we usually use lower gains on the minus scale. For 3D, we have to increase the gain. Sometimes I go up to 11 also. How do you optimize the image? So the volume angle should be 120 for Conuta. Quality is maximum. You ask the patient to hold the breath and not to move. So you press start or freeze button and the volume starts acquiring. You save the volume and select vol pre for a second volume. I'll show it how. So this is the presets on your machine. You have to make the angle 120. If you make the angle 120, both the cornu are included. So this is very essential for Konuta acquisition. So keep the quality to maximum. And for the ROI, entire area of interest that is fundus to the external loss. This is more important. If you don't adjust the ROI, you may not get the fundus completely. Then you can't diagnose Konuta without the fundal indentation. So this is a Valpri button I was telling about. After acquisition of the first volume, you just press this and again second volume is saved in your machine. So then after acquisition, play with your X, Y, Z and walkthrough knobs. Play with the render, multiplanar, OmniView, HD Live, Edit Light, Magic Cut, TUI, VCI. Using all these parameters is just smart diagnosis. Okay, your machine has all these presets, what I have talked for. You have a fixed ROI. You have presets especially for the endometrium and also for the myometry. You have edit light, magic cut, everything is there. So first you know your machine before acquiring a volume. So this is the image after immediately acquiring the volume. So this is the A plane, B plane, C plane, and this is the 3D plane. So here we have to play with this green line. Green line has to align with the endometrium. So now I have aligned my green line with the endometrial line. Now you see how nicely the 3D coronal image is displayed. So I'll go into the anatomical mode. You see, this is exactly the 3D image. So you can play with this surface mode, HD Live or HD Live Silhouette. So you can also use OmniView with VCI. So the difference is you can see the endomyo junction perfectly crystal clear endomyo junction with OmniView VCI. So what are all the diagnostic limitations? When the uterus is associated with adenomyosis or myoma, these conditions distort the shape of the uterus. So you must be very careful to diagnose anomaly in above cases. So in such cases, you take 2 or more volumes so that you can work on them after you finish your OPD. So if you suspect cervical anomalies, you take separate volume for cervix. For vaginal anomalies, you perform gel sonovaginography. For unmarried, when you see double uterus, when the uterus is mid-position, and you suspect renal anomalies, always go for transabdominal scan. So the limitations are there is restricted field of view in transvaginal. If the uterus is large, if the fundus is very broad, you can't acquire this in transvaginal. So patient habitus and the bowel shadows also impair your volume. So in mid position, you have to go for transabdominal. So myometrial contractions are the major diagnostic limitations, and I'll show you how they distort your image. These two images of same uterus taken a time apart. Here it shows a septum. After 15 to 20 minutes of scan, this is a normal uterus. This is because of myometrial contraction. This is again the images of same uterus. Here it is T-shaped. After 30 minutes, this is a normal uterus. So that is why suspicion should be in 2D. That is the first step. You suspect Konuta in 2D and then you confirm it in your 3D. So this is again the same uterus. Here there is thickening of the posterior wall. And after some time you see thickening of the anterior wall. And after some time there is no contraction, the uterus is normal. So in such cases, better to take a second volume after some time in subtle cases. Okay. In Konuta, getting a true mid-sagittal section is a challenge. This is a real challenge because this is normal, not normal uterus. The anatomy is abnormal, so getting the true mid-sagittal section is a real challenge. And one more thing is the green line has to exactly pass through the endometrial line. I have already shown you in the previous slide. So this is the same curvature as the serosa. And this green line has exactly passed through the common cavity in case of septum. This is even more difficult. So if there are two horns and the two horns are not in one plane, it is again difficult. So in such cases, you go for transabdominal scan with full bladder. So what is the role of MI? A good 3D volume is equal to MRI. I repeat, a good 3D volume, it is not simple 3D. It is a good 3D that is similar or replace MRI. But MRI is useful in complex anomalies, cervical or vaginal anomalies, for location of the rudimentary horn, in pediatric cases, and in mid-position uterus. So coming to the measurements, we have lines, angles, contours, thickness, ratios. Don't be afraid of them. I am going to clearly explain to you all these measurements. So your machine has all the measurements. It has got wall thickness. It has got internal midline indentation, even the fundal indentation angle. Please use these calculation knobs so that your job will be easy. So coming to the lines, we have three lines. One is interosteal line, the line joining the ostium and the internal os, the line joining the fundus and the endometrium. So this is the interosteal line from the right ostium to the left ostium. The second line is from the ostium to the internal os. The third line is from the fundus to the endometrium. So these are the three lines. If you are very thorough with measurement of these lines, it's easy for you to do measurements in conutta. So coming to the contours, we have two contours. One is external endometrial contour and the second thing is internal endometrial contour. You see the difference. This is fundal external contour and this is internal endometrial contour. We'll see the external fundal contour. So we have a convex contoured fundus or a flat contoured fundus. So both these uteri are normal. So when we translate it into ultrasound images, here you see a convex fundal contour and a flat fundal contour, and this is normal uterus. So what is abnormal external fundal contour? So you have to measure the distance from the interosteal line to the fundus. So this must be more than 5 millimeters. That is normal. So we'll see the abnormal fundal contour. This is according to Triani and McCarthy's method. You see the first thing. The distance between the interosteal line and the fundus is more than 5 mm. So this is a normal fundal contour. Here, the distance between the interosteal and the fundus is less than 5 millimeters. So this is abnormal fundal contour. Here there is no fundal contour. The distance is completely absent. This is completely abnormal. So what is normal endometrial contour? So we have a slightly concave endometrium, a completely flat endometrium, a slightly convex. So this is normal endometrium. So we'll translate it into ultrasound images. Slightly concave, completely flat endometrium, a slightly convex endometrium. Okay. So what is abnormal endometrial contour? So abnormal endometrial contour, we measure the distance. So the distance between the interosteal line and the endometrial surface is usually less than 10 millimeters and the angle is more than 90 degrees. So this is normal. As I have already told you, there is slight concavity. This is also normal. When is it normal? It should be less than 10 millimeters and the angle should be more than 90 degrees. So here the distance is more than 10 millimeters and the angle is less than 90 degrees. This is definitely abnormal endometrial contour. So what are all the abnormal endometrial contours? This is deep concave endometrial contour and arcuate uterus. This is a sharp dip in the endometrial contour. This is septum. Here it is incomplete. there is again deep dip in the endometrial contour and the septum extends up to the internal os. This is completely septum. You see this image. There is sharp dip in the endometrium and also there is fundal dip. So this is a bicornuate uterus. So we translate this into ultrasound images. There is deep concavity and the angle is more than 90. So this is not septum. This is arcuate uterus. This is subseptate and this is complete septum. So coming to the angles, we have three angles: internal endometrial angle, lateral endometrial angle, and T angle. We see. So this is the internal endometrial angle. This should always be more than 90. The lateral endometrial angle, this must always be more than 135. And the T angle should always be more than 45 degrees. I think I'm clear. Are the images clear?
Yes,
Excuse
madam.
me.
Very good. Excellent.
Very clear.
Thank you. So the thickness, the myometrial wall thickness and lateral wall thickness. So this is how you measure the myometrial wall thickness. In the coronal image, the myometrium from the external fundal contour to the endometrial contour. So I have already told you that more than 5 millimeters is normal. This is the way how you measure in coronal image. So this is the way you measure in the sagittal image. You measure the anterior myometrium and the posterior myometrium. A plus B divided by 2 is myometrial thickness. So this should be more than 5 millimeters. So the lateral wall thickness is from the lateral angle to the widest part of the lateral wall of the uterus. This again always has to be less than 7 millimeters. So less than 7 millimeters is normal lateral wall thickness. So these are the two thicknesses we have. So the ratios is a little difficult thing to explain in Zoom. So I'm just skipping this. So this is the ratio how we measure the myometry. So coming to the proper uterine anomalies. Okay, uterine aplasia already we have discussed. Here we do the karyotyping. 46XX is MRKH syndrome and 46XY is complete androgen insensitivity syndrome. But you can diagnose this even without karyotyping because in MRKH you see the ovaries. So usually ovaries are normal. You should do a thorough search for rudimentary horns. So MRI is useful for diagnosing the rudimentary horns. Hypoplastic uterus, already this is over. Coming to the unicornuate. Transvaginal sonography, here the uterus is not in midline. So it looks very normal in sagittal. So that is why we always miss unicornuate in routine scans unless you are in an infertile OP. But the uterus does not look normal in axial section. So on 3D, you see that banana sign. So unicornuate amounts to 20% of all anomalies. The most important thing in unicornuate is you search for the rudimentary horn. Rudimentary horn is present in 33% of the cases and it is associated with renal anomalies in 40%. So you have to sort for MRI to detect rudimentary horn. So the reproductive outcome is usually good. Sometimes preterm labor is common, so you can consider cerclage. So this is a classical banana sign, but this is a narrow banana. So this is again a broad banana because she is a paras woman. The same patient after conceiving, there is a gestation sac. So uterus diadelphus is complete failure of fusion of Mullerian ducts. So you have two uteri and two cervices. This accounts to 5% of anomalies. TVS is very difficult to render if two horns are very apart. So transabdominal ultrasound gives you good acquisition. There is figure of 8 in axial section, but you always look for the symmetry of the horns. Reproductive outcome is usually good, but preterm labor and cerclage may be considered. Atypical uterus diadelphus is Overa syndrome. So I'll show you this image. You have two wide horns with a gap in the middle. So I'll also show you The video of the uterus diadelphys. You see, the two horns are wide apart. This is a transabdomen. And you can see the cervix as you go caudally. And there are two cervical shadows. I'll repeat this. So you see here, you see two white dots. Two white dots are the two cervices. So this is one more case. You see, the cervix is very broad because she is a Paris woman. You can see two cervical canals, two uterine horns clearly seen in the transabdominal sonography. This is axial view. So on rendering, abdominal rendering, you see this widely placed two horns, figure of 8 appearance. So coming to the bicornuate uterus, it is incomplete fusion of the Mullerian ducts. You have two uterine horns with single cervix, that is bicornuate unicollis, and two horns with two cervical canals with a cervical septum in between. This is bicornuate bicollis. It accounts to 10% of all anomalies. An axial sweep, you see classical refringent endometrium. That is what I was talking about. You see two endometrial echoes in bicornuate uterus. The sagittal sweep shows short endometrium in the middle and it becomes long laterally and bilaterally. I'll show the video also. 3D confirms the diagnosis, but sometimes you may have to go for separate volumes for uterus and cervix. But the classical feature in bicornuate is there is fundal myometrial indentation. The obstetric outcome is good with cerclage. If there is history of bad obstetric history, Strassman's metroplasty can be opted. So this is the video clip you see carefully. The endometrium is short in the middle. The same endometrium becomes long on both the sides. So the endometrium is long, it becomes short, and again it becomes long. You see, long endometrium, short, and again it becomes long. This is a sweep. I'm not repeating the video. This is on the axial, classical birefringent endometrial echoes, the joining in midline, and they are wide apart as you go cranially. So this is the same image rendered. You see, there is fundal indentation and there is no myometrium in between the interosteal line and the fundal myometrial contour. So this is exactly bicornuate uterus. So this is a bicornuate uterus after the Strassman operation. Coming to the septate uterus. Septate uterus we have complete when the septum extends up to the internal os, incomplete when the septum ends in the uterine cavity and the length may vary. The classical feature is fundal contour is completely normal. So if the endometrial indentation is more than 10 millimeters and the angle of indentation is less than 90 degrees, you can exactly say that it is a septate uterus. This is most common, about 55%, and the most adverse outcome and the great problem in infertility OPDs. So what is the pathophysiology of the septum? It causes implantation failure because of less connective tissue and more muscular tissue. When there is more muscle, it causes myometrial contraction, constriction of Pinard's ligatures, decreased blood flow, inadequate desedialization, finally leading to implantation failure. So recurrent pregnancy loss in septum. Because of more muscular tissue, there is incoordinate uterine contraction, decreased vascularity. So it can cause both first and second trimester abortions. More thickness, more muscle, more blood vessels, so more complications. So when you see a very thick septum, you better assess this with your Doppler. Normally, the Doppler of the myometrium is 0.58. But in the septum, the RI is increased to 0.68 to 1.02. This is very important in cases of RPL. Though, how do you image the septum? It is always isoechoic to myometrium. The axial section shows classical two refringent endometrial echoes. The two echoes join in midline, so it is incomplete. If the two echoes do not join in the midline in axial sweep, it is complete septum. Complete septum is thin and hypoechoic caudally, that is lower down because of the presence of only connective tissue caudally. So the sagittal sweep, you see this video. You see a long endometrium towards one side. This is it. Short endometrium, and again it becomes long endometrium. This is sagittal sweep. And the entire video you see, fundus is intact. The fundal contour is normal. This is long endometrium, short endometrium, and again long endometrium. So that is the sagittal sweep. So we go for axial sweep. The two classical, two refringent endometrial echoes. So you see the echoes are wide apart. They are very wide apart cranially. That means that is septum. You can also see the shadow, just like edge shadow of the fibroid, because septum is nothing but myometrium. So this is how you differentiate bicornuate uterus from the septum. Here, fundal contour is normal, but here in bicornuate we have fundal dip. So you at the cranial end you see two uteri, but here it is only one uterus with two refringent endometrial echoes. This is what I am talking about. It becomes long endometrium. In the middle, it is short endometrium. And again, it is long endometrium to the other end. So what are all the implications of septal size? Septal dividing two-thirds of the uterine cavity is more likely to cause complications. So septal length is also measured and the remaining length of the cavity is also measured. So in your report, you mention the length of the septum and you also mention the remaining cavity of the endometrium. So these are all the various images. This is subseptum, complete septum with a broad fundus. This is complete up to external os. So for comparison, I have put this image. This is not septum. This is a wide angle. This is arcade uterus. So this is again the two refringent endometrial. When I rendered it, it shows an incomplete septum. T-shaped uterus. Previously, it was due to DES. Now it can be de novo also, usually acquired due to tuberculous adhesions. The diagnosis is only on 3D. There is narrow uterine cavity, thickened lateral walls, and corpus to cervix ratio is normal, that is 2:1. So for T-shaped uterus, all the three things must be positive. That is, the lateral angle less than 130, lateral thickness is more than 7 mm, and T angle is less than 40. If you see all these things, then it is T. This is T-shaped uterus. So when you compare bicornuate, septate, and arcuate uteri, coming to the fundal indentation. Indentation is present in bicornuate, absent in septum and arcuate. Fundus to endometrial distance is less than 5 mm. This is abnormal, but in both these things, it is more than 5 mm. Endometrial angle, we measure only in septum, that is less than 90. In arcuate, it is more than 90. And endometrial indentation is more than 10 in septate and less than 10 millimeters in arcuate. So what are all the classifications? We have so many classifications, but the latest and the perfect classification is SRASJ. But classically, we follow ASRM or AFI classification. This is the old classification. So it has great mishaps. So that is why it is again re-evaluated and a new classification was designed in 2021. So this is the latest classification. Now it includes all cervical, vaginal anomalies and also the complicated anomalies. So this is the thing I was talking about, the septal angle and the length. So the ESHRE-SJ classification is the best classification. The deformities are described in ascending order. The arcuate uterus is named as a normal variant. Bicorporeal septate is a new addition. But the demerit of this classification is complicated nomenclature and it is difficult for the clinician to understand. So usually for reporting, we follow ASRE. So these are all the various types what I have described. X-ray gives a beautiful images. So X-ray classification, the reporting is along with the classification, there is a place for the drawing of the anomaly and this is the best reporting. So how do you report the anomaly? You mention the size of the uterus and you also describe the fundal external contour. If measurement can be given, you can give that. Endometrial contour is described. Depth and angle are given in the report. The septum, whether it is complete or incomplete, you measure the length and thickness of the septum and length of the remaining cavity also. If the thick septum is there, you assess the Doppler and give the RI. In unicornuate uterus, you mention it whether it is right or left cornu and can you see any rudimentary horn that can be mentioned in the report. So associated cervical and vaginal anomalies can also be described. And finally, you give a line diagram of the anomaly for the clinician to understand and for the surgical procedure to be addressed. So this is the line diagram of the conutta. It's very difficult, so I'll take it step by step. First, you see whether uterus is absent or present. Uterus absent, it can be MRKH. If the ovaries are present, it is 46XY. And if these are absent ovaries and it is XX, it is complete androgen insensitivity syndrome. Uterus is present. Is it a small uterus? Hypoplasia. If it is a normal uterus, whether it is single cavity or a double cavity. If it is a single cavity, is it banana shape, is it T shape, or is it triangular? If it is triangular, then you see at the fundus. If the fundus is convex, you see the endometrial contour. Endometrial contour is flat or slight concave, it is normal. It is more concave, but the endometrial angle is more than 90 and the thickness is more than 1 centimeter, then it is arcuate. If it is banana shaped, it is unicornuate. You look for the rudimentary horn. If the cavity is absent, it's okay. If the cavity is present, you see whether it is non-communicating or communicating. If it is T-shaped, you should measure all these things, the T angle, the lateral angle, and the lateral wall thickness. Then you go for double cavity. If you see double cavity, then you look at the fundal contour. If the fundal contour is convex, whether it is complete or incomplete septum. If there is fundal indentation, then you can see indentation. If it is complete, it is uterodidelphus. If the indentation is complete, it is bicornuate or bicorporeal septate. So the rare anomalies are the Ovira syndrome, Robert's uterus, and Acom. So Ovira syndrome is a mnemonic. It's an obstructed hemivagina with ipsilateral renal agenesis. It is atypical uterus diadelphus. It is very difficult in 2D and 3D because the DD is difficult. I'll tell you the DD. So you have to sort for MRI and excision of this atypical septum. The next thing is Robert's uterus. Robert's uterus is asymmetrical septum. This is the asymmetrical septum. This is the blind obstructed part. So the resection of the septum has to be done. Here again, MRI is very useful. And the girl presents with progressive dysmenorrhea. And the third thing is ACUM, accessory cavitated uterine malformation. This is again atypical Mullerian anomaly. The girl presents with progressive dysmenorrhea. So you have to excise this cavity. So when a girl presents with progressive severe dysmenorrhea, you have the following differential diagnosis. It can be a non-communicating cavitatory rudimentary horn, a Robert's uterus, a Ovira syndrome, ACUM, or juvenile cystic adenoid malformation. So these are the differential diagnosis. But the juvenile cystic adenoid malformation is not Mullerian anomaly. It is adenomyosis. But on ultrasound, all these things look similar. A non-communicating rudimentary horn, a Robert's uterus, a juvenile adenoma, and sometimes the Ovira syndrome all look normal in ultrasound. So in such cases, we have to go for MRI. And finally, the take-home message of Konuta. I'll give you the Panchasutra mantra of Konuta. Start with transabdominal sonography. 3D TVS is gold standard, but please keep in mind the limitations of transvaginal sonography. 3D coronal view is the standard for Konuta. MRI for cervical and vaginal anomalies. And finally, but not the least, know your machine first before you actually go for volume acquisition. So I conclude my talk with this saying, Konuta are the mistakes in the creation of God the Almighty. We as surgeons sometimes prove ourselves greater than Him by rectifying these mistakes. Thank you very much. I am honored and I am obliged. Thank you very much for this opportunity, Vidya, for you.
Thank you, madam. Anuradha, madam.
That was an excellent talk, ma'am. Dr. Vidya. Yeah, your
Yeah.
comments.
Anuradha, madam.
Yeah. So thank you, madam, so much, Jai Bharti, madam. That was um, very well, explained, and very good pointers you gave how to differentiate between arcuate, subseptate, septate, and biconvate. I think these are problems which we encounter very frequently because most of us IVF specialists, we are all doing our own ultrasounds. At least I do my own ultrasound. uh, so I think everyone should be aware of this. And since we are IVF specialists, these all most of these problems do lead to delayed childbearing amongst women, our patients. Infertility is associated, and fortunately some of them are correctable. And septate uterine, if we resect these septum, we get fantastic results, and patient will conceive and the risk of abortions and all will decrease. But at the same time, some of them, we can't correct, and we let it be. But at least putting a circlage at the right time and monitoring them with good progesterone support is also giving us good live births. But yeah, some of them congenital, we can't do anything and we let it be. And some of them go definitely into surrogacy also. So madam, this was a wonderful insight, and if there are any questions from anyone, we can take it right now.
Can I invite Dr. Rajashri Palladi, madam? She is our next Kasuga president. Madam was around. Madam, are you there?
Yeah, welcome, Rajeshri, madam.
She's there.
Yes, yes, she's there. She has moved.
Rajashri, madam, can you unmute yourself?
Yes. Good evening, everybody. And
Welcome,
thank you,
madam.
Shilpa,
Hello, ma'am.
for inviting me for this wonderful talk. I think I would have really missed a very important, smart presentation by Dr. Jaya Bharati, who has made this explanation of congenital uterine anomalies so very crisp, simple, and understandable by everybody. I truly appreciate her efforts to simplify the topic and make it so acceptable and understandable to everybody. I wish that we have more such talks. And as Dr. Anuradha mentioned, that the congenital anomalies, yes, they are there, but then the smartness to diagnose, identify, and manage. And very rightly put in Dr. Jay Bharati that sometimes the surgeons may prove beyond God to help such patients and give them the benefit of having a child. Thank you so very much for this lovely presentation, and I appreciate and congratulate the Infertility Committee of Kasoga for consistently giving very good lecture series, and I'm sure that the same memento will continue in the year to come. Thank you all.
Right.
Thank you, ma'am.
Thank you. Thank you, Rajesh Madam.
Madam is
Dr.
our next
Jayabharati,
Kasoga president.
last but one slide was very good, Dr. Jayabharati. Before the thank you slide.
Thank you.
Very
Whatever
nice.
Panchasutra you have given, we should stick in our OPD.
Yes.
Yeah.
Really.
I even liked the short videos which Madam had put, it was so
Yeah.
understandable.
Fantastic. And this will be an asset for the YouTube in the Kasoga Chronicles.
Yeah,
Yes.
it is
We can
recorded in
always go
Krishna.
back and look at it whenever we are in doubt,
Correct.
We must go back
Thank
and
you,
look.
madam. Thank you so much. Thank you for your wonderful lecture and being a part of Karnataka State Obstetrics and Gynecology Society webinar series. Definitely, we are going to look forward to having you again on this stage with us. And thank you so much. And I would really like you to, come to Bangalore and teach us all this in physical, not
Thank
only
you.
in
Thank you.
webinar, physically. Definitely, we'll have some program arranged. Thank you so much. Thank you, Dr. Shilpa. Thank you, Dr. Rajshri.
Yeah, she is very good teacher.
Yeah.
And I should thank
I'm
you,
very much
Vidya, for
respecting her.
arranging, this talk by Madam. Thank
Yeah,
you.
one more talk, endometrium. It was lovely. I was asking her, but she said I will give this. So next talk is endometrium. Madam, you are
Yeah,
fixed with
sure.
that.
Yes.
Sure.
One
Sure.
question.
More sessions in infertility by Dr. Jay Bharati in
Yeah,
our
She
sure.
had,
Is
I'm
there's some
obliged. I'm
question?
obliged.
There's some
she had
question.
given this in
Madam.
Hyderabad also.
Thank you.
Not this one, madam.
Madam, there is a
Very
question.
different.
There
When
is
we are
one question. Please read out.
Madam, while rendering, when the uterus is mid-posed, so how do you do it, madam? Like,
So by transvaginal scan, rendering of mid-position uterus is difficult. If you can manipulate your probe, you can make it anteverted or retroverted. It is even difficult with this manipulation. Then you have to go for transabdominal rendering with a partially filled bladder.
okay. But whatever the manipulation we do, again, as you said, rightly said, it is difficult to get a good 3D view when the uterus is mid-posed. Yeah.
I think we can move forward, and if there are any further questions, we can send by WhatsApp to Madam. We can, Dr. Vidya, please
Yeah,
take over and continue.
yeah. Wait. I'm having some technical problem.
Welcome, Dr. Mahadev.
Thank you.
Hi. Thank you, Bharti Madam, for your talk. It make my next panel very easy because you told us all the points for diagnosis and all the points to use for our clinical diagnosis. I'm sharing my slides.
Excuse me.
Yeah.
Before that, can we share our CVs?
No,
The panelist and expert
I
CVs.
have done short CVs in my slides.
Okay.
We will do there because now time is.
She has compiled everything, na?
Yeah, I will.
Okay, done.
Undiagnosed conjunctiva can have very bad obstetric complications. So it's very important to have the diagnosis in hand so that we can.
Are you able to see my slides?
Yes.
Yeah, these are the. But same, I am getting that line, Arun. Okay. This is our panel on congenital anomalies of uterus. Most of the part of diagnosis is covered by Bharti Madam very excellently. I'm really happy to invite her, and I'm really glad to get a teacher like her. And I welcome my co-moderator Shilpa Haresh for the panel. And our expert, Dr. Basavaraj Devarshetty, Treasurer of KISAR and from Vishwas Fertility Center, Bangalore. Dr. Mahadev Hanwad, Director of Spandan Hospital, Janani Fertility Center, Hubli. Dr. Sujay Heranjal, MC member of KISAR, Shirur Hospital, Bagalkot. Dr. Satvik, EC member of KISAR, IAG, Karnataka, Medgood Hospital, Belgaum. Dr. Rekha Rajendra Kumar, EC member of Kasoga, Miracle IVF Center, Bangalore. Dr. Nagesh Kumar, EC member of KISAR, Janani Fertility Center, Tumkur. Dr. Rashmi Patil, Chairperson, Quiz Kasoga, Apollo Hospitals, Bangalore. Dr. Richa Pal, she is from Bangalore, Manipal Hospitals, Bangalore. So I welcome you all for the panel. These are my esteemed panel. So we will go to practical pointers only. The congenital anomalies, classification and all the things are already discussed by the madam. So I want to know from you, why should we, as an infertility specialist, routinely screen for congenital anomalies? Sujay? Sujay, are you there? Hello?
Yes, ma'am, I'm there. I was mute.
Yeah.
So that's what we all know that, ma'am, that congenital uterine anomalies are associated with recurrent pregnancy losses and bad obstetric outcomes. And majority of them are asymptomatic also, and that might be the cause for infertility. And there are certain abnormalities like septum, which are identifiable and correctable. So we need to know all of this, and evaluation becomes a way more, very much important for us in terms of evaluating an infertile couple.
Yeah, and also in IVF failures, thin endometriums and abnormal cavity shapes are very important for our embryo transfer decisions. And we can correct and intervene before any embryo transfers.
Yes, ma'am.
So these are the most important things in reproductive age group: septate, T-shaped, unicornate or bicornate uterus. So diagnostic tools, I think madam has already covered. If anybody wants to say anything.
Has she covered on HSG?
No.
No, ma'am.
No. Yeah, Rekha madam?
Yeah. Sorry, it's coming in another one also. Am I doubly heard?
No. You are.
I'm not able to mute that. Yeah, HSG, yes, of course, what she has told, like 2D, more than 2D is a 3D scan that matters. And many of the times it replaces the MRI scan. We all know that, and we don't have to ask for the MRI scan. The HSG will definitely give additional information than the anomaly. It gives us the other problems like the tubal patency, etc. The other information what as infertility specialists we need. But certain things again, like the what do you call the non-cavitary, like non-communicating horn of the uterus. These things we are not able to make out by the HSG unless they indent the endometrium, the myometrial expansion and indent the endometrium. We will not be able to make out. So it is I can say HSG or SSG are the supplementary investigations, but HSG is more for than HyCoSy. HSG is more for the supportive for the diagnosis of the conjugal.
Yes, madam. Thank you.
Madam,
Thank you
as an
for
initial evaluation, I think pelvic scan, that too, especially 3D TVS, gives most of the information, even including the tubal pathology, if there is it is helping. But here we are talking about conota. So before subjecting for HSG, I think 2D followed by 3D gives the best.
No.
I mean, yeah.
Yeah, Dr. Nagesh, that's what I was telling. The first investigation is 2D and 3D for conjuta. But many of, since we are all infertility specialists, it is not just the conjuta in our practice. Our background is little different, like patients do come with infertility to us. So the HSG is a supplementary investigation.
Yeah.
That is what
No. She was telling about tubal evaluation will be also covered and we get diagnosed. That's
No,
what
but the
I'm
thing
not
is,
talking about the conjuta diagnosis alone.
Yeah. As
But
a
here,
full infertility workup for a patient,
Yeah.
HSG we usually do. Yeah.
no, but the thing is, madam, so the pelvic scan gives the direction next, whether to do tubal evaluation or you have to go for hysterolaparoscopy. So when you find something abnormal, and if you quantify the diagnosis, then we can think of further method of tubal evaluation. That is either HSG or histoscopy and laparoscopy. So where in histoscopy and laparoscopy, see and treat. So that's the thing. Especially if you find a septa, we can easily treat. It's easily treatable by doing minimally invasive endoscopy surgeries.
No, need not be. Many of the times, like people like Dr. Jayabharati, if she is giving you almost a diagnosis of the bicornuate uterus, where you are going
No
to
need
treat,
of
or the
laparoscopy.
didelphys uterus or unicornate, made, you are not going to do additional information by doing your laparoscopy. You will, in that case, if you want to do tubal evaluation, you don't have to subject the patient for anesthesia and OT. She has given you the diagnosis of conjuta. Now your extra information, what you want is knowing your tubal patency. I'm talking of the infertility part. Diagnosis is almost done by 2D and 3D.
Yes, madam. Any comment our expert want to give? Basara sir, are you there?
Ma'am, no point to add in the physical examination because most of the time the vaginal symptoms, everything, just the examination we get to know. So that history and the physical examination, the diagnosis even begins with that part.
Yes.
As clinical, I think clinical history like dysmenorrhea, and second thing is speculum examination. As a routine speculum examination can help us, and a normal 2D scan. And if you have specialty, if you find any difficulty or if you find suspicion that there could be any uterine, then you do. Most of us, I think, we have 3D scan as a fertility specialist, and that gives us almost all the information. And as they discussed, there no need to do laparoscopy if there is a clear indication of a unicornate uterus or bicornate uterus or didial phase, unless there is a unicornate with and all, you can or associated endometriosis or associated hydrosalpinx, then you can think of doing a laparoscopy instead of HS.
Thank you, sir. If the ultrasound is giving diagnosis of treatable anomaly by laparoscopy, you go for laparoscopy. Otherwise, tubal evaluation and you can go ahead.
And as Dr. Rashmi said, the clinical somebody is talking.
Can I talk?
So 1 minute, let me finish.
Sure. Can we go ahead?
1 minute.
As
Dr. Rashmi said,
best message.
the clinical examination per speculum, per vaginal will give us lot of information, and per abdominal mass you will be able to find. The history itself is progressive dysmenorrhea, and many times androgen insensitivity syndrome also you can make out many times if you are very keenly observing the patient.
Yes,
Some
madam.
karyotype.
So can we go ahead? Yeah, I think our Baswara sir, Rekha madam and Nagesh sir has given us all the points practically, and Rashmi also added that it is very important to do per speculum examination of each and every patient who is coming to our OPD. Only going and doing ultrasound is not sufficient for those patients. And
can I add one more point?
Please, sir.
Yeah. Sonosolfingography along with the 3D color Doppler will give more better evaluation of the tubes as well as the lumen. You can add color Doppler and pulse Doppler also. With SSG, that will give the best possible this one. And accuracy is up to 92 to 95%, almost equivalent to chrome tubation with hysterolaparoscopy. But non-invasive and cost effective also.
Yes, sir.
So better you to add color Doppler with SSG. Thank you.
Yeah. So no contrast.
Now contrast media also come. Ecovist has come.
Yes.
And you can add little air bubbles also. So that you can delineate the tubes much better because the air bubbles act as a positive contrast. Saline acts as a negative contrast.
Yes.
So all infertility specialists, better they use SSG along with color Doppler. They give more information. Color flow can be easily picked up by the color change in the blue and red on the screen.
Yeah. Thank you, sir.
Thank you.
Thank you, sir. Dr. Satvik, can you give the role of hysteroscopy in diagnostic algorithm or in it as a treatment part?
Yes, ma'am. Hysteroscopy, definitely, I think we all are aware that hysteroscopy is not the first line of diagnosis. A good 3D ultrasound will be a gold standard for diagnosis, but definitely hysteroscopy is indicated in cases where we have recurrent pregnancy loss or in failed IVF cases with recurrent implantation failure. There, definitely a diagnostic hysteroscopy is a must and a compulsory thing we have to do, because so many times we see small subseptates that can be only picked up by good hysteroscopy.
So hysteroscopy we do as a part of and limitation is we cannot assess the external contour.
I'm trying to unmute.
Please mute yourself.
Please. Can you mute from your side? It's not getting muted here.
Arun, please.
Admin, can you mute me? It's not getting muted here.
Any comments from the expert?
Any comments from the expert? by for hysteroscopy?
Dr.
Can I-
Basavaraj?
No, hysteroscopy, I think if the 3D scan shows that everything is normal, there is no need unless thin endometrium, fluid in the endometrium,
Yes.
or if you have any T-shaped uterus or septate uterus. So diagnostically, in case of only thin endometrium, any fluid in the endometrium, but therapeutically, yes, in either septate uterus or that's the
T-shaped
indication.
uterus.
And we
T-shaped
can
uterus.
also diagnose endometritis and also adhesions sitting with the
Correct.
ostia, covering the ostia, which makes a tubal block. And with histoscopy, when there is a synechiae covering the ostia, we can also do
Yeah,
what is
we are
called
running
proximal
short.
We
tubal
are
Yeah,
cannulation.
talking
Yeah.
only of
Conuta.
conuters.
We are
We
talking
are
about
concentrating
conuta.
on conjunctiva.
In hysteroscopy, we can talk later. This is a conuta panel. For in regarding with conuta, that there is no diagnostic role. If
Yeah.
there is septum or T-shaped, we can go ahead with surgery. That's all.
Has a therapeutic value than diagnostic value.
Yes, yes, yes. Thank you, madam.
So,
Shilpa, do
uh,
you want to continue?
this question is to Dr. Rekha. Which anomaly has strongest evidence for improving outcome after correction?
Yeah, undoubtedly, according to my practice and as I have read, it is the septate uterus, especially the subseptate uterus. As you have put partial septum, it gives a lot of improvement in the patient. Like it helps for not only the infertility, it also helps for the improves the take-home baby rate, like the abortion, early pregnancy losses, preterm labor, all kinds of obstetric complications. Also, it takes care of.
Any role of surgeries in any other conuta in your practice? What do you feel apart from septate?
Like
Septate
I
definite
don't
evidence is there.
septate is the one which is maximum rewarding. There are other minute surgeries which are yes or no kind of surgeries, like the lateral metroplasty for unicornuate or Strassman's. They are almost obsolete, I can say, because there are many studies which have shown that these kind of yes or no kind of surgeries have not helped much the patient regarding the untoward obstetric outcome and take home baby rate, unlike the septate uterus, which is categorically a satisfactory surgery.
Yeah, Dr. Mahadev,
Strasmus
can you put
metroplasty is also
how?
like it is helpful, ma'am, but definitely the case selection needs to be correct. Only in
Yeah.
patients where they have had previous multiple failures, Strasmus metroplasty does give its result, but of course it has its own risks also.
Dr.
And,
Rashmi, any role of surgery in non-communicating haunts?
I think more it would be towards the symptomatic relief rather than towards the fertility challenges, madam. So it is depending on what presentation she is coming with. So in the non-communicating, it would be more of her symptomatic reliefs.
No, what, Dr. Madhav, will you comment on how, what is the steps, care you will take by for hysteroscopic resections? Are you there, Dr. Madhav?
Yeah, fine. Yeah, actually, this septate uterus is my favorite topic. In this, most of the time, the septate uterus can be very easily diagnosed, as previously told by speaker, by 3D ultrasonography. Histoscopy is not necessary to diagnose. In septate uterus, mainly it is a therapeutic. So, if the septum is complete till the cervix, then or septum is subseptate, then better go for resection. And the more important thing in septum resection is try to resect the septum with scissors. If possible, try to avoid using cautery because it might damage the basal endometrium. But sometimes what happens, if the base of the septum is quite big, so it's very difficult to sometimes resect with scissors, or you may need sometimes 3 or 4 scissors to resect one septum. So in that case, I usually use this Collins knife under a normal saline using bipolar cutting cautery. So I cut with the septum with the Collins knife. But what happens is, if the base of septum is very quite big, so in that case there is a chance of formation of adhesions. So it's better to put some barrier inside the uterus. Either you can put the number 8 Foley's catheter with distilling the balloon with normal saline, or you can put inert copper tier like to prevent the adhesion formation. But in my experience over 15 years, I have seen if the patient has undergone septolysis for a broad-based septum, there is invariably the formation of adhesion at the fundus, causing difficulty in development of the good endometrium for further treatment. So I usually do relook hysteroscopy after 2 months. But before that, after doing septolysis, we usually give E plus V for consecutively for 2 months and do relook hysteroscopy after 2 months. If there's any formation of adhesion, do radiolysis and then continue treatment. The only thing is how to know that you have done complete septolysis is once you always go from below up, cutting the septum side by side, and once you see both the ostia in panoramic view by keeping the scope at the interloss, that is the end point. And most of the time, the beginners tend to perforate the uterus. Even if you perforate the uterus, nothing to worry, it's not going to cause anything. Just abandon the procedure. If you feel you have done incomplete resection, repost the next cycle and you complete the process.
Thank
How
you.
many
Dr.
days would you
Saraswat,
like to
want
keep
any new
Foley's
comment?
catheter, Dr. Mahadev?
Usually,
How
I
many?
keep for 5 to 7 days.
Okay. Dr. Basavaraj, any comments?
I think I think septum I think is rare. Most of the time we see usually simple partial septum. And what Mahadev told is absolutely right actually. So basically avoid ovulation to prevent the damage to the basal endometrium. Use the scissors and see if it is not broad, just we give estrogen for 2 months, 2 to 3 months, and then give withdrawal bleed. And usually call at the end of 2 months to do a 3D scan once again to check, if the septum is complete. Then I usually give a withdrawal bleed and then get a period. Then we can start with the treatment.
Yes.
I just wanted to ask for the benefit of the audience, the panelists, who are all of us using the Foley's catheter inserted inside, or it is just the estrogen? Because I use just the
No, ma'am.
estrogen.
Yes,
I don't
And I use only estrogen.
only HRT
Very thick,
is missing.
Cyclical ENT.
No, if the base of the septum is quite big, then invariably there will be formation of adhesion. So better to put Foley catheter number 8 for 5 to 7 days in order to prevent adhesion formation. It's better always. If for a small septum, you can avoid. You can just put on HRT.
Okay.
And one more practical point. While doing the septal resection, the intrauterine pressure should be optimum. When that is so, and the end point of cutting while using scissor or usually we use scissor. So when there is a little sputter or when it appears red, I think that time we have to stop it.
Now we are
Cutting.
going to have AI guiding us when we should
Yes,
stop.
yes.
That will be the next inventions that we're going to see. Next question is to Dr. Satvik. What is the management approach for T-shaped uterus with RIF?
Ma'am, for a T-shaped uterus, a good lateral petroplasty will definitely help a lot. That basically the problem here is the reduced cavity size. So doing a good lateral petroplasty and even correcting the upper part of the cornua part and the fundal part of the cavity. Once you increase the volume, we do get good results.
Yeah, Dr. Richa, what problem you get during infertility management in a T-shaped uterus?
So
Dr.
usually
Richa
in
Pal.
T-shaped, usually in T-shaped uterus, the cavity will be narrow. So to for the body and cervix ratio will be maintained, but because of the lateral wall thickening, to increase that receptive, we do that lateral longitudinal incision to the lateral walls to increase the cavity size and make it receptive.
And many times the endometrium will be not growing properly.
Not growing.
So we cannot, it is difficult to get pre-treatment procedures before embryo transfer. Basaras sir, you want to comment anything?
No, I think that's right, basically.
Yeah.
And
So
as
any role of
afterwards
PRP
only.
at the time of surgery? Any of the panelists would like to take the question?
Only thing is try to avoid using cautery when you are doing lateral metroplasty. Try to use scissor, whatever to the extent possible.
And as Dr. Jayabharati said, it may be secondary to tuberculosis also.
Yeah.
Can I give one viewpoint?
Yes.
So, if you are having persistent thin endometrium, then as well we try hysteroscopic subendometrial injection of PRP. I think there is no harm in trying that, and we have been doing, and we do get better results with endometrium developing well, along with the estrogen therapy. I think these
Which
are the
conditions
cases
do you
where it
suggest, Dr.
can
Anu?
Yeah, you can do PRP here.
For T-shaped, wherever you are suspecting thin endometrium.
Yeah.
Mainly T-shaped uterus, right?
Yeah.
So I think it's general for thin endometrium. I think Dr.
Yeah, generally for thin endometrium, we try PRP. That is there. Okay. Okay. Shilpa?
Yeah. This question is to Dr. Nagesh. Should hemiuterus, unicornuate uterus, and bicorporeal bicornuate uterus should undergo surgical correction?
Normally, these when the cavity size is relatively adequate, it will be small only, but if it appears relatively adequate, no need to do any corrective surgeries in especially bicornuate and bicornuate uterus. And hemicornuate sometimes it will be very narrow. We can give a trial of lateral metaplasty if there is a repeated uh, early pregnancy losses. I mean the mid-trimester losses.
Do anybody feel that unicornuate uterus you should do lateral metroplasty because all the walls are already thinned out? What do you anyone want to comment?
I want to comment here. It is as Dr. Nagesh said, yes, but most of the times, by God's grace, these uteruses do expand with musculature. The cavity gets expanded reasonably somewhere between 28 to 30 weeks, and we are going to increase the gestational age of the baby by additional cervical encerclage, which is a must in all the cases, according to me, these kind of cases, because otherwise we can at least postpone these cases by 4 weeks if you give a good cervical encerclage and monitoring of the cervix. It is not just monitoring of the cervix and your progesterone going to help. The cervical encerclage is must in these kind of cases where we can prolong the progestation.
Anyone believes in pre-pregnancy cerclage during hysteroscopy diagnosis or anything, or during pregnancy only you do? Please comment.
I do in pregnancy.
During pregnancy.
Again, in
After
cases
12
where
weeks,
recurrent pregnancy losses, for them, yes, pre-pregnancy surplus will be useful.
Laparoscopic.
The patient has undergone recurrent second trimester abortions with unicornuate bicornuate uterus. Better to do pre-pregnancy internal tightening laparoscopically than during pregnancy.
Basaras sir, you want to comment?
I think if there is a prior history with the short cervix and all, then you can consider going for.
What do you recommend, pre-pregnancy or post-pregnancy?
If there is previous history, yes, if previous history pre-pregnancy. If there is no history, then you go for.
Yeah, even if she is primary, if this diagnosis is made, cervical cerclage is must.
After pregnancy.
Yeah. If she is already having bad obstetric history, you can do pre-pregnancy cerclage and manage.
So how does the pre-pregnancy cerclage weighs better than the post-pregnancy cerclage, Dr. Rekha?
Pre-pregnancy, I have not done, but maybe I will give some explanation for what they are saying the pre-pregnancy. I always do after 12 weeks anomaly scan is done with the diagnosis of unicornuate or bicornuate. I do pre-pregnancy probably right from the beginning. It will not allow the cervix to that internal os to dilate and that slow effacement of the cervix, that softening of the cervix, whatever that molecular things that happen there, probably it prevents right from the beginning. I don't know, but I don't have experience of pre-pregnancy cerclage in these patients.
Anyone does pre-pregnancy cerclages here?
Laparoscopic cerclage, when we put, it's always above the internal osnum. So the level of cerclage is very high. So it is more secure and the less chances for it to open up and give way.
Anyone does pre-pregnancy cerclages here?
Also.
I think Dr. Satvik, Dr. Mahadev does.
Yes, ma'am. We do.
If there is a previous history of recurrent mid-trimester abortions.
Why not post-pregnancy is my question.
That's what it will be above the internal os and giving better support.
That's what. Dr. Basavaraj, your comments?
No, I think see the more chance of sometimes the operative damage and all can happen during pregnancy. If there is a short cervix, previous history of anything, it is always better to do prior to the pregnancy. But very significant.
Pregnancy law, there is no harm in putting pre-pregnancy. No, we already see undergone recurrent abortions. So why you
it is preventive? It's a kind of preventive surgery than a therapeutic surgery when you are doing it pre-pregnancy.
Yes.
I think and another thing what we do is suppose we have put a Shirodkar stage or lap stage, we do the cesarean section, we don't remove. For the next pregnancy, it will be pre-pregnancy only.
Yes.
Shirodkar can be removed, ma'am. It can be removed.
No, we may not, I said. It can be removed, I said, but suppose you want to keep, you've done a section, you may not remove. You will keep the chirurgical stitch for the next pregnancy.
Yeah, if we do section. Okay,
So
next
take up
question to
In
Dr.
in
Richa.
expert hands, the pre-pregnancy cerclage can be done if they are expert in laparoscopy. Otherwise, routine obstetric practice we do during pregnancy cerclages only.
Yeah.
Suggestions.
Yeah.
Okay.
But in
Next question to
unicornate uterus, unicornate uterus, always if it is a primary infertility conceived with either naturally or with minimal assistance or through IVF, I think it's worth putting prophylactic encerclage is because of the volume expansion will be less. So it's better to put, as Madam Rekha Madam said, I think it's worth putting prophylactic encerclage in all the unicornate uteri.
Yeah, don't think that you will monitor the cervix, you will wait for that funneling, etc.
No,
and
no, no.
No.
Because that pregnancy is
Encerclage is
precious for the
definitely
patient.
indicated.
Yeah,
But
because you will not be
After
monitoring
NT
it
scan,
daily. One day she'll
After NT
suddenly
scan.
come with expelled fetus.
Prophylactically
monitor
after
See, the
early
problem is if the NT scan is abnormal, if you have put a pre-pregnancy encerclage to terminate, it's a very, very big problem. So that's why I'm telling post-pregnancy, you know the status of the baby. That is my practice.
But my one theoretical answer is, if you are putting pre-pregnancy laparoscopic cerclage, if you put the knot posteriorly, and if you find during pregnancy there is a abnormal NT, so you try opening the POD, cutting the knot. That's a theoretical answer. I am
It
not
will be very difficult, sir. It will be totally fibrosed. It will be totally fibrosed. I don't think so. Laparoscopic encerclages can be removed.
No,
It
if
will
you
be
put
very
not
Now there is a newer technique to put laparoscopic cerclage, ma'am, in which the knot is placed in the vagina only, outside. So we can remove those kind of
Still, there is
sutures.
fibrosis in the abdominal region, no, Dr. Sakri.
Yes, ma'am. Yeah, it is still
I
difficult,
differ.
but yes,
My
ma'am.
practice is to put it post pregnancy so that we can conveniently remove it anyway.
I think abdominal cerclage, I think mainly for very short cervix, those conditions, I think it will be helpful. That's what I feel.
Dr. Basaraj, probably best of both the worlds would be in the first pregnancy, you do the post cerclage and maintain that cerclage as a pre-pregnancy for the next pregnancy.
Yes.
There is a question, ma'am,
Unless
from
you do,
Bharati madam.
I think we should do post pregnancy cerclages only because as Shilpa said, there may be abnormal baby which it will be difficult to remove that baby. So only with short cervix, very short cervix, where we can put pre-pregnancy cerclages.
There's a question, ma'am, from Bharati madam. Cerclage for all conuta.
No, it is not the question. It is not the
I think it's a
question.
comment.
Okay.
Answer.
It's a comment. It's a comment, not answer.
So by default for all conuta, we put cerclage.
Yes, by default you should put all conuta.
Because it is not the length of the cervix here. It is
the
the
strength of the
quality of the
cervix.
cervix.
The tissue, how it's
He has
the
not put a
tensile strength and
question
the
mark
tissue
there.
is different in the conutas.
Except for arcuate,
All
ma'am.
the guidelines are going to give us, we may agree to disagree on various points, but individualize every patient and go ahead with your best clinical practice.
But whatever, Rashmi, 2 points are very, very clear. How many ever studies you go through? One, septum removal is very rewarding. Second thing, in unicornuate, cervical stitches must. These are very important.
Cervical stitches are must.
Studies you go through, it is confirmed statement.
And laparoscopy
Better
is
to
not
put a stitch
compulsory
and
for
give a
pregnancy.
live birth, successful live birth to a baby rather than repenting having a miscarriage.
Okay, last question to Dr.
Madam, this Dr. Jayabharti madam, this is for septal resection. You do cerclage, for septate.
Yeah.
Partial
Same
septate
thing.
uterus. Yeah.
Yes, same thing.
Ma'am, not for arcuate, right?
Arcuate, they are considered
Arcuate is
normal.
associated more with more of preterm, but the thing is it is not diagnosed usually. Arcuate is associated with more risk of preterm labor, but the pre-pregnancy diagnosis is not made.
So better to put in
So by
arcuate.
default, cerclage for all conuta. Even if
What
you
about
do
septate
surgery
uterus
also.
post correction?
Yes, you are correcting the septum, not the cervix.
Not the cervix.
Not the cervix. You are correcting septum.
They will
By
have
default
defective
weak
cervix.
in conuta.
And also,
Of all
any
the
operative hysteroscopy, if we have done, better to put in cerclage. Any operative, even for septal resection.
But when there is a complete septum, we can leave the intracervical septum that itself acts as a cervical encerclage that can be done. And in a septate uterus, if it is a singleton and also in arcuate uterus, I think case to case we can we can decide. So
I think we should not remove the cervical septum, Dr.
But in spite
Basavaraj.
of that, you have to put a cervical stitch. That is what we are saying.
Better not to remove that, no? Cervical
Yes, but
septum will be not.
don't remove, but put the stitch.
Yes, yes.
And even we have seen that
Even
whenever
bicornuate uterus, you are putting cerclage, Bharti madam?
Yes.
Yes,
That is
better.
what I told
Yeah,
by
that is an indication
default.
actually in
Yeah,
bicornate.
bicornate,
default.
unicornate, and
All the cornuta we should
Yes.
do
If
cervical.
cervical septum is there, still we are putting cervical encerclage.
Yes,
No need actually in such
but the
cases.
problem is these cases are not diagnosed unless it is an infertility clinic. In
Yes.
general OPD, these things are not diagnosed.
Yes, madam.
So, ma'am,
And
you
when we
suggest
do
even
a
for
procedure-
cervical septum cases, cervical encerclage?
Yes.
Okay.
And
Arcuate
one more
uterus is
point
the
to add
only
on,
one
ma'am.
that is
Dr.
normal.
Richa, will you comment how these congenital anomalies, if you diagnose, how your IVF planning will change? Dr. Richa is there?
Yeah, ma'am. I'm there, ma'am. So, as we have seen, like this congenital anomalies, they are associated with narrow cavity or abnormal cavity. So, technically, they will make the IVF, this embryo transfer and all difficult. So, before that, we can go for this trial transfer. First, second is it can help. It will help us in planning, like how Madam told, like prophylactically cerclage and all we can plan. So,
Yes.
after transfer and all, we can plan prophylactic cerclage after NT scan. So that is there, and also for because the cavities are smaller in dimension and all compared to the normal cavity. So only single embryo transfer, what I
Yes.
think
Important. That's
should be
important.
That's very important.
Dr. Rashmi, you want to add anything, Dr. Rashmi?
Ma'am, to the previous discussion, I have seen in the clinical practice that preterm labor or short cervix, even while doing a hysteroscopy, post any cervical procedures that have been done, that itself is a factor. So when we are doing corrective surgeries added on with the procedure, again, it brings them more towards the cervical incompetence as well. So better to go ahead with the cerclage. This I wanted to add to the previous one. And as Dr. Richa said, negotiating the path or mock transfers can be tried before planning an IVF cycle.
Another thing I want to add is that, especially in T-shaped endometrium, endometrium, in HRT cycles, you may not get a proper because of estrogen supplementation.
Yeah. Anyone wants to add? Baswara sir wants to add anything?
Rekha ma'am, can you repeat? I couldn't hear. What did you tell?
I said thin endometrium one should anticipate in these cases, especially T-shaped endometrium.
Yes.
I mean, uterus, I said. Other than whatever you have mentioned, that insinuating the catheter, that this and all, that mock transfer, everything. And one should remember the communicating horn of this also, while the embryo transfer.
Yes. Baswara
You have
sir.
to write and keep.
No, I think first is correction of anything, like mainly if there is a septate uterus, it has to be corrected because it does increase the chances.
Yes.
Leave 3 months time before you transfer. Meanwhile, you can carry on with the IVF if you're doing the IVF after the surgery.
There is increased risk of ectopics with this.
Yeah. Sorry?
There is increased risk of ectopics with these.
I think it's mainly they're saying the unicornate uterus. But yes, any abnormality, especially the bicornate or unicornate, more risk of ectopic pregnancy. And trial transfer, as Dr. Richa told, and most important is single embryo transfer is most important here. We have to. It's one of the important indication that everyone has to follow single embryo transfer in these cases.
And most of these patients come to us with recurrent implantation or recurrent pregnancy failures. So these points are very important.
Counseling is very, very important. Lots to counsel here.
Yeah. Counseling is very important.
Yes, cervical circulation and also has to do counseling regarding the risk of preterm labor and malpresentations, increased cesareans.
Adverse
obstetric outcome.
cervical stage, ectopics, so many things.
So they should be near the hospital, reachable condition,
Yeah.
especially
These are treated as high risk
Yes,
obstetric
yes.
care only.
Up to the neonatal ICU setup. Till there, we have to explain.
Exactly.
Yeah, it
And
was
especially
very.
when you put a cerclage for a septal correction patients. So when the cervical encerclage was put, I think patient should be informed regarding the tightening of the abdomen, back pain, all those things.
To reach
And
hospital.
sometimes they may come with ruptures also.
Bucket handle tears of cervix can happen
Yes,
if they don't come on time. Then we will have a lot of problem to suturing those
and
tears.
if somebody has overcorrected, they may fundal rupture may also may be there.
Exactly.
And
And
removal of
we
the
had a
stitch
patient
also.
in our experience who had undergone pre-pregnancy laparoscopic internal tightening. She was a precious pregnancy and she was a wife of a teacher. From third month till 9 months, she used to visit our hospital every 15 days, saying that pain abdomen, pain in the abdomen, pain abdomen. Every time, everything normal. Out of frustration, we got all MRI also done. Everything is normal. Only thing is she was not it. She was in need of counseling. That no problem is there. You carry on. And
And
when we
I have
section at 9 months, when we
I have
open,
seen a case of laparoscopic encerclage leading to fistula,
yeah,
bladder,
Yes,
that's
vesicle
what you
erosions.
try to put the knot posteriorly when you're doing pre-pregnancy laparoscopic internal tightening.
Dr.
And
Madhav, I
Dr.
think most of the gynecologists, they find difficult to open the
Yeah,
posterior pouch and by
yeah.
the
So
knot and remove it is difficult.
yeah.
So now I think they are putting the stitch, in the vagina.
Yeah.
Stitch just
Dr.
above the os and
Mahadev,
bring the stitch in the.
Pre-pregnancy is very easy to put knot posteriorly. During pregnancy is difficult.
Yeah.
Pre-pregnancy you can do posteriorly.
No,
Dr.
as
Dr.
a message
Mahadev,
to all the participant, we should tell them that you should do cerclage after early anomaly scan only, not pre-pregnancy is not
Yes, yes.
routinely done, and no one, everyone is not expert in doing this, and the removal of the baby may be difficult.
Dr. Vidya, in continuation of Dr. Mahadev Hanawat's patient's history, just want to add one or two points. One point I want to say is that when they come with the psychological issue as pain all the time and all that, don't consider, especially once they cross 24, 26 weeks, be all the more careful and just don't be carried away by thinking that she always complains of this. You may have to really watch the cervix, these kind of cases, because sometimes it happens that she really comes in pain. You might have thought that she tells that every time. So don't
No,
brush it aside like
thorough
that.
examination,
No, I'm
just
not
don't
telling for you, I'm telling in general. And second thing is, always tell her in counseling that you have a stitch and you have to get the stitch removed after the delivery.
Yes.
Especially when they don't come to us. And if the message is not carried to the another, they go for delivery to mother's place, some rural place. They may not even know that there is a stitch sometimes.
So we should write in bold
In
letters
paper,
on the
yes.
Yeah,
family, on the
very
file of the
At the
perfect.
patient
top.
that
Yes,
cervical
yes,
circulage
exactly.
is done. Because in
Exactly.
emergency, if patient goes and that
Yes,
obstetrician will not see
yeah.
the file and all.
Especially if it go for cesarean mother's place, and the stitch may remain like that only if you
And
don't
you should
enter. These
tell to the relatives also that
yeah,
these things are
these are the
done.
2 points
And this
I
is
wanted to
important.
mention.
These are the important complication if you don't remove the stitch.
Yeah,
Because
these
this
are the two
happen.
important things I wanted to mention. Thank you.
Yeah. So this was very excellent panel discussion with very good take-home messages from all of the expert panelists. I want one of you each give a take-home message. Start from Satvik.
Yes, ma'am. I think one thing is like once the patient comes, especially who are practicing infertility, diagnosing these anomalies is very important. First ultrasound, first clinical examination is very, very important. All your suspicions, everything starts from the first visit. So I think diagnosing and have a strong index of suspicion for these cases, because I think more than around 8 to 10% of infertile patients do have congenital anomalies.
Yeah, Sujay.
I think majority of us have 3D ultrasound. I think it's better to have a 3D volume probe with all the gynecologists now, so that we can screen each and every uterus, so that we don't miss a conutum.
All should be trained in doing 3D ultrasound now.
But I think just a screening is okay. Majority of can
Yeah.
just can screen, yeah.
Yeah. Richa?
Ma'am, once diagnosed with this, I think counseling plays a very important role in this. So we should take extra time, and treatment everyone does, but the thing is counseling. Counseling is something like we have to prepare the patient mentally. What can be the aftermath? What all complications she can face? So I feel we should give more time to counseling and thorough counseling, and everything need to be documented.
Patients are getting afraid with the diagnosis of that my uterus is abnormal. So counseling them positively that you may get pregnant and these things are there. This is very important, as Richa rightly said. Rashmi?
I believe every center should have a good sonologist like Jayabharti madam, or make your ultrasound tool yourself and get yourself trained well to diagnose these uterine anomalies yourself, and counsel them that with good treatment and corrective surgeries, yes, you can give them a successful live birth.
Yeah, Dr. Madhav?
Give them a positive hope that Carnota is not the indication for surrogacy. Because they think that my uterus is abnormal, I cannot conceive, will go for surrogacy. So give them positive hopes with proper counseling.
Yes. Dr. Nagesh?
One thing I think each and every gynecologist should learn doing the basic 2D and also 3D ultrasound scan, which I think nowadays, in 2D scan itself by doing a the sagittal section, and also when you turn the probe to 90-degree and sweep up and down, we can make out, you can suspect actually at least. So when the endometrium is getting split, so then those cases can be subjected for 3D ultrasound scan. And I think as Jayabharti madam said, all Carnota should have a encerclage post-pregnancy after NT scan. But when there is a recurrent pregnancy losses in such cases, maybe lap interval cerclage can be done.
Yes.
I think 3D is a must for all infertility
3D is must for all the first scan, first basic workup. 3D should be included in infertility workup.
I think that changes the direction, like how, in which direction we have to go.
And each consultant should do their own ultrasounds.
Yes, that is very important.
Don't depend on any others ultrasound.
For gynecologists, ultrasound is like a stethoscope for physicians.
Stethoscope.
May I add? May I add?
Yeah.
Lord Mahashiva has his third eye.
Yes.
As infertility specialists, you all have this previous probe as your third eye.
Third eye, yes, madam.
Yes.
As third finger.
Third eye.
But I
You
think eye
already
is
have
eye.
10 fingers.
Yeah, eye.
Because you see with the previous probe.
As madam rightly said, we do basic scans on second and third day. We should follow the patient until secretory phase and again see those patients, because in secretory phase we only see ovulation and endometrium, that's all. We never, because some anomalies may get missed in our day-to-day 3 scans and they may get diagnosed in secretory phase. So secretory phase doing
also do a scan for corpus luteum. Can you do a scan for corpus luteum? Then you can finish the 3D in secretory phase.
That's what we do. Scan mainly basic scans routinely. Secretory phase we do as we monitor. So that time also we should do detailed scanning. Many times we do see endometrium, see ovulation and finish off.
But this pre-ovulatory also is good actually. No, it can still you can diagnose pre-ovulatory.
Each patient while monitoring, you should see basic what are the problems. Only second day 2 or day 3 scan may not get some pointers to us.
Dr. Shilpa, just on some done summary of 4-5 slides.
1 minute. I have not given my take on the same.
Okay. Rekha madam and Basura sir.
After that, we'll finish. Yeah, just wanted to say there are 2 things here. One is that many times come with the diagnosis as a scan report of the abnormal uterus, like whatever cornuta. That time the husband, mother-in-law also have to be counseled, because otherwise they'll think that she will never conceive, or she has to have lot of investigations further to get pregnant, or pregnancy wastage, etc. There's a marital disharmony may happen. This we have seen in our practice, all of us. Because something
it is diverse with the scan report.
That's what I'm saying. Counseling is very, very important. Other than that, once you take it in your hand, then it is a multidisciplinary approach, right from the infertility specialist, then the ultrasound specialist will do 2 things here. One is for the diagnosis, Dr. Sangamitra, please mute yourself. One is for the diagnosis of cornuta, and second thing is once she gets pregnant, then again the fetal details like the IUGR, small presentations, the placental placentation, the many things they have to diagnose. So the ultrasound specialist or the sonologist will be with us throughout that pregnancy. Then also obstetrician should know how to take care of the cervix and delivery plan, when to give steroids, etc. The fourth thing is neonatologist also should be sensitized. So it's a multidisciplinary approach.
And
Thank you.
it is not that hysterolaparoscopy is must for each and every cornuta. Only correctable cornutas can be posted for hysterolaparoscopy, not for diagnosis.
It adds value to the treatment.
Yeah.
Of
Baswara sir,
infertility.
Baswara sir, give an expert comment and then Shilpa will finish.
Yeah, just I will just give me.
I have one point to make that over enthusiastic resections and lateral metroplasties just do enough which is required, because there is lot of placenta previa and placenta accreta which can happen, and the pregnancy itself gets complicated, and placenta accreta is very very dangerous for the patient. Maternal mortality also can happen.
Yeah.
So we have to be very careful in what we are choosing and what we are doing for a patient.
I think the summary of the presentation done by Madam and also the very useful discussion during the CMA. So I'll just say that it is most of them are asymptomatic, and majority of them are detected incidentally while doing an HSG or doing a scan. And most of them they have a normal reproductive outcome, because when you do cesareans, when you try to clear the placenta anything, then you find out there is a septate or it is a bicornate like that. And very few of them experience adverse reproductive outcomes. So accurate diagnosis and correct classification is very important. Appropriate counseling of the woman and regarding the prognosis, the risks, and the planning for any intervention you want to do before she goes for any treatment. Next is, I think, just it's only 5 slides, very simple. How to diagnose clinical examination, like clinical history, like severe dysmenorrhea, progressive dysmenorrhea, and local examination for septum, vaginal septum, or time and per speculum for double cervix. 2D ultrasound and HSG, they are adequate for simple screening. 3D ultrasound is, it is a important diagnostic modality of choice, and you don't need MRI. MRI is only to confirm and diagnose more complex anomalies, like Madam was telling about other diagnoses like Robert uterus and other diagnoses like that. Vaginal, cervical and vaginal anomalies are best diagnosed by MRI. Histolaparoscopy, as told, is gold standard, and mainly it adds if there is any associated adnexal pathologies or tubal pathologies or rudimentary horn endometriosis, you can consider it. And most important, as I told you, 1/3 or 1/5 of, or 1/3, I would say, of uterine anomalies are associated with the renal anomalies. So important to always scan kidneys. HSG, we know that it basically, because we cannot see the external counter, it's very difficult to differentiate between septate and bicornate. But looking below the picture, if there is a very wide angle of indentation, endometrial indentation, then we say probably it is an bicornate rather than septate uterus. So that's one of the things we can make out. And in HSG, we sometimes fail to see the non-communicating rudimentary horn. So regarding 2D scan, when you're doing 2D scan, there are some of the ways you can identify there may be anomalies. One is transverse plane where you can find double endometrial complex more towards the fundus actually. So if they're widely placed, it can be bicornate uterus or it can be didelphys, or if they're very closely spaced, it can be septate uterus. So this can give some information for us. And again, it has to be confirmed by doing a 3D scan in the coronal view. We can see the indentation or not. We can make out. Next is sorry, in the sagittal. Sorry, this is again the unicornate uterus. Can sometimes be there may be indentation if there is associated non-communicating heart in unicornate uterus. Otherwise, it's very difficult to diagnose a unicornate uterus in a 2D scan. And longitudinal plane, while I think the Jayabharti madam explained very well. So when you're doing a complete sagittal section or transverse section. So we have to move the probe from one side to other. When you move the probe from one side, the uterus disappear. Again, if you go to other side, you will be able to see one more uterus, one more like structure in the side. So this information is very important, mainly in case of tidal piece or in complete bicornate uterus will be made out. And in unicornate uterus, sometimes when you do even the longitudinal, sometimes the uterus can be tilted towards one side. And I think these are some of the images. I think we know the lines and the indentation. So again, treatment as such, treatment should be indicated only in case of bad obstetric history or prolonged infertility. Suppose there is a paper where says that you have come, the patient come to you for 6 months with infertility, and you're done is you found a partial septate uterus. Again, there is a evidence shows that you should not operate for septate, unless it is a complete septate uterus. You can do it, but simple partial septate uterus and other things you should not operate unless there is a bad obstetric history or prolonged infertility. Septate uterus, a very good, very common anomaly, very high success rate, and septal resection gives a very good success rate. Unicornate uterus with rudimentary horn, non-communicating rudimentary horn, you can remove it. Rudimentary horn also you can remove it because sometimes it may be difficult during embryo transfer, you may miss it. Putting embryo. T-shaped uterus with thin endometrium, and we can consider a lateral resection. So I think this is the summary of
Yeah.
Thank
you.
today.
Thank you, sir.
Thank you, Dr. Basavaraj.
Thank you.
That was excellent take-home messages from you. I thank all the panelists, our expert, Dr. Jaya Madam, and our Kasuka office bearers, Dr. Durga Das, Dr. Shobha Gudi Madam, and Dr. Rajshri Palladi Madam for this opportunity. I really appreciate it. Was a wonderful panel with a lot of take-home messages, very practical. I thank all of you for this active participation. Thank you, everyone.
Thank you very
Thank you,
much.
Gasoga. Thank you, Shilpa.
For Madam's
Thank you, Dr. Vidya.
For Madam's talk, we had almost 60 participants, and now till 2 hours, there are 30 staying here. So
we will definitely call her again for our endometrium.
Yeah, it is fixed.
Yes.
As a clinician, it's our responsibility to identify these anomalies early, counsel the couple appropriately, and individualize management. Doing so, it's not only improving their pregnancy rate, but significant impact on their emotional and physical journeys during pregnancy. So thank you all the panelists. Basara sir, special thanks to Bharti madam and Anuradha madam, Rajeshri madam. Thank you.